Here you can see these implants. They're stuck here in Schlemm's canal. Those are very good implantations. They look well. Very often you will see these implants in very different places here. You don't need to take them out. You can, of course, if you find them, but not always they're in the right spot. What is a proof of having a good penetration, that the implant is in the right spot? How would you know that? Bubbles of which bubbles? Where do they come from? From the inside here. There is no air in there, but there's something else in there that you can see. When you lower intraocular pressure, Schlemm's canal gets filled with blood. Exactly. And so when you put in an implant, you will have a reflux of blood here. So you can choose your IOP during surgery, and you just lower it down, and if blood comes out of these, they are set perfectly. So this is a good control. Yeah, that's just a larger magnification. You can see the trabecular meshwork here. Down here, this would be scleral spur. And then there is the trabectome. You have the collector's channels here. And as I said before, not every collector's channel works as well as the next. There can be differences in outflow. And so they come up with the trabectome idea. They said, well, why don't we just scrape off a larger area? And then the chance is higher to hitting the right spot, which is true. But still, anyway, the procedure works better in younger patients than in older ones. It's a procedure that has a limited time that it works. So usually after 2 to 3 years, the efficacy of these procedures go down. One thing that is not used very widely, some use it. There has been great expectancies. And there is the hydrous implant, which is a metal implant. And you can see here how one of these is put in. So you target Schlemm's canal here, and then you slide in the thing. And then it clicks off, and the implant is in there. And it's bigger also, again, because of the variability of outflow, because it's not everywhere the same. And with a larger implant, you cover a larger area of possibly increased outflow. The suprachoroid is a really smart space to put in implants. And this is from 1989. This is before you were born research. And you have supraciliary space. You have suprachoroidal space. It's the space underneath, between choroid and sclera. And when you measure the pressure in these areas, when you put in a sponge here that you can measure the pressure inside, you get very different results. And what's important is that in the supraciliary space, IOP seems to be quite low. And so why not put in an implant that puts the fluid in there? If there is low pressure, this could be a good sink to use. And that's what people did. And in the past, wedges were introduced to make a ciliary cleft. Some of you maybe have seen post-traumatic ciliary clefts. Sometimes these eyes have a very low pressure for a long time. And that's exactly that mechanism. And when pressure goes down, you need to make sure that it's not too low, and this never happens because you always have some pressure left here. So it's a perfect situation, actually. Problem is just that post-traumatically, these patients scar over time, and then IOP goes way up. And so if somebody has a very high pressure and you don't know why, always ask the patients if there was some trauma in the past. And in the past means in the past. So it could be 20 years ago. So even after a very long time, these pressures can go way up. But if you keep the cleft open, you have a very good situation in terms of IOP. And the CyPass implant from Alcon, that's not available anymore, but there is a new one, it's the mini-checked, was put in here. So you can see here between the sclera and the choroid, there is an implant. And here you can see how you put it in. So you seek the scleral spur and you get underneath it. And then you slide it along the sclera, you slide it to the back. So has anyone seen one of these? What we do now is that we check these patients for endothelial cell loss, because these implants have the tendency to move. They can move outward and then they scratch on the cornea. Or if the patient scratches the eye, you know, it comes towards the cornea. And so what we do, if we see that there are rings on there that give you an impression how deep the implant is inside the choroid, when it's too far out, we just cut it off. So we take a little scissor and cut it off, and then patients are fine again. Never pull them out if you see them. They have holes in the backside. When you look here, they have holes here. And so fibrotic tissue can grow in there. And there are some YouTube videos where some person just rips it out, and that's a real mess, you know. That gets you choroidal bleedings, big time. So don't do that. If you see one, cut it off. Take the time and cut it off. This is how it looks like when it's too far out. It shouldn't be visible actually. As you see here, there is only one ring that extends, so it should be back here actually, but it goes to the front, and those you need to shorten. So the endothelial cell loss is the problem, and I think this is that's one of the procedures where we cut one off. You can see the implant here. Shall we turn down the lights a little more? Yeah, that's better. So here is the implant. And you can see 3 rings here. Of course, you look from the front, so it doesn't look very big. Here you can imagine it. It's just too long out. There's the cornea already up here. So that is one that needs to be cut off. Yeah, you see the rings. Usually they're implanted superior nasally. You find them there, and then you grab them. And always be gentle, you know, don't pull too much, just a little bit. And the tweezers you take should be at least 20 gauge. So you have the force. And that's the part that was cut off now. And then these patients have no problems. So it's just when they stick out too far. And that is another suprachoroidal implant. It's the Glaucoma implant, and you can't buy that also anymore.
About the previous one, problem with the endothelial cell count, the standard
No, well, what happens, the cells are killed here. And what happens to the rest of the cells? They expand, you know, the whole cornea like moves in that, so it's a sink. It's like a sink of death for endothelial cells. So they just move towards that sink, and when lots of them have moved and died, then the others have just gotten bigger, and that's what you can measure. You can also try to measure here, in this area, of course. That gives you probably a better leverage of early diagnosis. Yeah. So this is another one. That was the eye stent company Glaucoma. They built the eye stent Supra, and the results were quite good actually at the beginning. Sorry. At the beginning they were really good, but somehow they took it off the market. So we suspect, I haven't been involved in this study, so we suspect that endothelial cell loss was a problem here again, because that sticked out even further. This is this titane ring. There is an old trabeculectomy, and they put it right here in the same spot. And then there is the mini check. This is still available. And it's this sponge-like structure that you have here that you put in with this inserter. That goes also here between scleral spur and choroid. You move in. It's a rather crude procedure. It's pretty big. But they changed the inserter now. They make it a little sharper in the front. So, you know, there are patients where you need this. There are patients that have no conjunctiva, for instance. And then you are left with cyclodestruction and suprachoroid. Those patients come up from time to time. The sponge inside has this special arrangement of chambers that prevents scarring of whatever. So we will see about this. We don't have really good data so far, but the next years will show if this implant is a good one. So here is a. Do we have a break actually? I didn't ask.
So the lecture should have been from 8 to 9. Now it's 9 to 8.
Oh man.
So I don't know. We could finish this one. And
Yeah.
Go into the coffee break and then.
Yeah. Let's finish that one. Why is that not? Can please, yeah. So there you can see the SN45 implantation. It's a gelatin stent. It's basically a little tube made of gelatin that you put here under the conjunctiva, and you insert it with an inserter system. And you stick it through the cornea. So you go in rightly above the trabecular meshwork, and then you come out here, and you do the insertion of the implant then. So here comes the implant now. And when it's all in, you retract the inserter. So it's sticking out 1 millimeter in the anterior chamber and roughly 2 to 3 millimeters here in the back. So this is the implant here. It's really small. The inner diameter is between 45 and 60 micron. And that's how it looks from the inside. And with this implant, it doesn't seem to make a difference how far it sticks into the AC, because it's so soft that it doesn't seem to cause any problems with the endothelium. So at least in the last 7 years, we haven't seen any problems. That's how it looks like inside. Then it makes a little bleb out here. And that's the inside. The interesting thing is that this gelatin, once you've put it in, starts swelling, as you can see. And when it swells, it fixes itself in the implantation canal. So by getting bigger, it's fixed and doesn't move anymore. That's the pressure flow. It's another implant. Gets put in very similarly, but from the outside. So you have to open the conjunctiva from the outside, open up everything. And that is the beacon implant, brown, that you put through the cornea. It looks like this. So that flow takes place from here to the outer surface. And this was a trial that I didn't take part in because I was afraid that having a permanent opening into the anterior chamber might cause problems with infections, and that was the case, and that's why the trial was stopped. Then you have the trabeculectomy. You do these surgeries, you get blebs. You have deep sclerectomies where you open up Schlemm's canal with a double cut. Canalostomies, where you put in probes into the canal and then you distend the canal. Gives you a better outflow also. Then you can put in also a suture that where you tension the suture and it sort of tenses up the trabecular meshwork. Then you have the tube shunts, the big plates. We're using those not as a first resort. Moorfields Hospital is just a real fan of these implants. They put in lots of them in the first place, but it's a big surgery. So once you've done this, this quadrant of the eye is dead. Yeah? There is no other possibility anymore. That's an Ahmed valve. It's a nice valve because it has a built-in resistance. So pressure doesn't go to zero when you put it in, and you don't have to tie off the tube, which in the others is necessary. There's now a new G implant that has a lower diameter of the tube, which also has a little resistance to it. You can see that silicone tubing, and these do cause endothelial cell losses also. So always make sure that you look at the endothelial cell numbers in these patients. The tube shunts should be covered, once they are inside. So I don't do it like that. I enter roughly here, and then you have no erosions of the tube. That's important. This is a Barfeld valve that you can see here, and it's really important to put a piece of sclera or something over the tube so that you don't get the erosions, because over time they do erode. There was a primary tube versus trabeculectomy study, and there was no major difference. After 5 years, they basically have a very similar outcome with a slight edge to trabeculectomy even. And that was always our impression, and so we didn't put them in as a first-line therapy. And now Moorfields has to change its first-line strategy also. If you can do a nice trabeculectomy, why not do a nice trabeculectomy? It works, we know that it works, and why put in a tube? And there is also the TAG study, where they tried to do primary trabeculectomy for advanced glaucoma. So without eye drops and so on, just do primary trabeculectomy in advanced glaucomas. And that also resulted in a similar quality of life with a lower pressure, of course. So these eye drops are a hard thing to do for the patients. And patients would give away years of their life if they wouldn't need to put in these eye drops anymore. And so this study was very well done, and And they could show really nicely that a primary trabeculectomy, well done, is better than putting these patients on eye drops, because advanced glaucoma means lots of eye drops. Oops. Yeah, there is, what's important for you to know is when you put in implants with a larger diameter, there is still the same flow that goes through. There is only 2.5 microliters of aqueous that's produced in the eye. So if you make a larger hole, it's the same amount of fluid that comes off, but it takes less pressure to push it through the implant. That's why pressure goes down. Sometimes surgeons will tell you that you have a higher flow when you make a larger opening. That's not true. There is just one flow in the eye, and you can modulate that flow with eye drops. You can like put in carbonic anhydrase inhibitors, then you have less flow. But a larger lumen just doesn't give you more flow. It's just a matter of understanding how these implants work. Yeah, that we had. And then there's visual field progression.